Merci tout le monde d'être là aujourd'hui. So, Tim, it's really an honor for us to have you here. So Tim is from Deakin University in Australia. He's an emergency physician. He's a leader. He leads basically accreditation, I think, in emergency medicine in general, but runs the emergency medicine academic program at Deakin University. He's well known all over Australia and the world. He's a top researcher and clinician in Australia, and Australia's really, I think, has taken the lead in rural emergency medicine. And so it's only fitting that we have the pleasure of inviting you here today as our first really international guest in the Living Lab, Tim. How are you today?
I'm very well. I'm very pleased to be here. I think that's selling my attributes even more than I would feel comfortable with on a CV, where everyone makes their curriculum vitae look as good as possible. So thank you. But I certainly like working in rural health and rural emergency medicine. That's what I like to do the best.
And Tim, we know each other now since about 3 or 4 years, I'd say. So how did we connect at one point? I remember you were in the U.S. and you actually took the train to come and meet us. And what was that story again?
I can't remember exactly how I came across your name. There's not many articles written in rural emergency medicine, and you'd written a few, and I think we connected by email. And I was in Washington for the American Society of Emergency Medicine meeting, ASEP meeting, and caught the train up. And I was hoping to get to Bay St. Paul, but we couldn't quite get there on the day. But we got to meet in Quebec and look around the university and the hospital, and that was fantastic.
And you met our dean, Dr. Poitras, and met a few people on our team. So that was quite a moment. And then we worked together. We presented together in a conference at Wonka in South Korea. And we've been in touch. And as of late, you've read our paper on the Living Lab, and we certainly asked you what you thought of it. And we'll talk about this a bit later. But I'd like to, could you tell us what you know from Australian emergency medicine at this point? So would you, because from afar, we envy you with the helicopters, the Royal Flying Doctors, the telemedicine. It looks like you're years in advance from Quebec's perspective. Is that the case? How do you feel?
It's fantastic at looking at other people's health systems. You only see the good things. So every health system seems fantastic when you look at it from the outside. It's like when your kids come home and tell you that, their friends' parents let them do this thing and that thing, and don't give the whole picture. So you only see part of the picture. But I think in part of rural medicine, Australia has done very well. Australia is really very similar to Canada, I feel, in rural medicine. I can remember late at night driving home and hearing an interview on the radio on an unfamiliar station about isolated hospitals and Indigenous health and trouble getting money and recruiting, and thinking it was a story about Australian health, but at the end finding out it was a story about Canadian health. And for the whole 20 minutes, there was nothing really that would differentiate a rural Canadian medical problems from Australia. I think we face pretty much the same challenges. I think rural generalism, which is a really proud thing for Australia, I think. General practitioners or family medicine doctors who have a special skill in obstetrics or emergency and work in rural towns is good. It gives some social capital to people who work in those areas, so they can hold their head up high when they talk to their friends who are neurosurgeons and and cardiologists, that they're doing something of value that is valued by other people. I am not a rural generalist. I'm an emergency physician. And I think sometimes in the emergency part we don't do as well. I think we still have an urban rescuer view of emergency health, and I think we put lots of money into teams sweeping in and taking people out when they're really sick. But it's my belief that where rural emergency departments really struggle is missing complicated presentations and difficult presentations of disease at an early stage. And I think they struggle there because that's where everyone struggles with emergency medicine. So sending people home with tummy pain that turns out to be a heart attack, or people who are a bit faint but are just edging into septic shock. So I think we don't do that well at those kind of things. A little bit, I imagine, for the same reason that Canada does, that we're divided up into states, and the good ideas from one state or one province, I suppose in your terminology, don't make it to the next province. So there are aspects that are fantastic in every state, but together we're not quite there. Some bits are fantastic, some bits not quite there.
And so you addressed an important problem, which is training and the maintenance of your skills in a rural hospital. And certainly we've highlighted that in some of our studies. Do you believe that's the case? And how do you in Australia deal with that, to making sure that, because in a rural hospital you're not exposed to as many as a big caseload as an urban. So I mean, we could debate that. You're only the only person on shift with all the cases that come, and they're not that many, but you see everything. Or you have 5 residents, colleagues, and everything. So you may see lots of cases, but you're not necessarily going to be the one treating that case. So there's a debate on that. So what do you think of that? Do you think, how have you organized that in Australia to make sure that doctors are always...
So there's a real dilemma, I think. I run the emergency medicine certificate and diploma program. So we have, we don't have, what if you have the College of Physicians and Surgeons as an overarching body that recognise people. We have colleges at a smaller level. So there's a College of Surgeons and a College of Emergency Physicians and a College of... So I work in the College of Emergency Medicine to run the certificate and diploma of emergency medicine. So we run a 5 or 6 year fellowship program for people wanting full fellowship. And this program is either 6, 12 or 18 months for people who want to work in emergency medicine without spending the whole 7 years. And often that is for people who will be rural generalists as well. And we face the dilemma that when we think about being alone in the middle of the night with a really sick patient, we think we really need to teach people everything, because that's really hard. That's as hard as emergency medicine gets. But then when we think about trying to recruit people into the course, we think we can't put everything in there because then no one will do our course. And it's the same when you're a hospital administrator. You get to say, we can increase the standard that we require, the qualifications we require of people in rural hospitals, but then we face a possibility of replacing a shift with a doctor who doesn't have every qualification that you want with an empty shift that you can't recruit people. And I don't know if you're finding the same thing, but for towns where the family medicine doctors run the emergency department that are seeing 3,000 to 10,000 people a year, it's very hard to recruit doctors already. And we're finding gaps in the roster. So you've got to try and find a sweet spot between having people with enough training to do the job, but not so much training so onerous that people won't work at all. I mean, I could talk about this for forever. So please break in and direct me. I think I think part of it in Australia is if you want to deliver babies at a rural hospital, you need to have a diploma of obstetrics. You can't just say, well, did family medicine, I did 3 weeks as a resident and I delivered 5 babies as a student, so I'm going to go and deliver babies by myself in a rural hospital. And if you do have that diploma, you get paid more. But if in an emergency department, you can have done a small amount of work in medical school and no rotations in a rural hospital, and then you all of a sudden you're doing a locum shift to a country hospital, and you're there in the middle of the night with a septic patient, and it doesn't seem fair, but you're not being paid more. People who have those qualifications not paid for. So that makes it a little bit hard to recruit people to those kind of positions.
And of course, you touch an issue that's critical here as well in rural Quebec and in Canada. Recruitment and retention of physicians is a big issue. A few years ago there was a report by the Quebec government and that actually 10,000 emergency shifts were covered by what we call médecin dépanneur every year, which cost a lot of money to the Quebec government, millions of dollars actually. So it's a problem. In Ontario, actually, the question of qualifications, Ontario is the biggest province in Canada. A few years ago, there was this big debate where they actually required that every doctor working in an rural emergency department actually be either a specialist or have the extra certification by the College of Family Physicians, the EM certification. And that put at risk many, many rural hospitals in Ontario. And there's a big upheaval, a big uproar vis-a-vis that. So it's a challenge, right? You have nobody or you have someone and you could work on their skills and that. So it's an interesting, but in Australia, you could evacuate people quite easily. You're not hit by big weather, the snow and the ice. You have this Royal Flying Doctors, famous program in the helicopter. So can you explain to us what is the Royal Flying Doctors?
So for some states, Australia is really best not to be thought about as a big country, but a small country very stretched out. So we all live along the southeast coast and there's a big gap in the middle. It's not like the Midwest of the US where there's people everywhere. It's like the north of Canada, very, very similar. It's just small communities, very separated. And as part of that, in the 1920s, Uniting Church Methodists decided to develop a retrieval service based in planes with people coming back from the First World War. And they developed a pedal radio that if you pedaled it hard enough out on your isolated cattle station, you could send a signal that you needed the plane. So that works in most states, that if you call for help, then the plane will come out and land at your cattle station or your small town and bring you back to a larger centre. It also does a whole lot of clinic work as well, and a whole lot of primary health. They do have trouble recruiting doctors as well, and sometimes the doctors there are more primary health than critical care, and so that is a bit of a problem. I've worked in a tiny Indigenous community and started a patient on inotropes and had to have them turned off because the doctors didn't know how to use inotropes. So those kind of things can happen. But it's developing more to separate its primary care from its emergency care service. I feel a bit guilty saying about this because all Australians are very proud of the Flying Doctor service, and it is an icon for us. And I feel a bit guilty speaking to an international audience saying that it's not perfect. We love it, and it's got some very good things, and it is great when it comes to arrive, but it's not perfect. There was I read an article by Tandy, someone from Canada, I can't remember her name now, and the rural doctors were complaining how long it took for planes to come, and that's the same with the flying doctors too. It doesn't cover Victoria, where I work down the south, or most of New South Wales. We have advanced care paramedics. Especially in Victoria, we put a ridiculous, maybe ridiculous, that they spend more money on the ambulance service in my state than they do on the largest hospital in the state. And the paramedics are amazingly fantastic. They are so well trained. They're often ex-commandos, so they could probably, fight a war while coming down on a rope and then doing an ultrasound to a quick echo to see what the heart's going on, and then plan the resuscitation. So very impressive. But we often wait 6 or 8 hours for a patient to go out. I don't know, how long do you wait for patients to go out? I imagine it's the same. And it's not only the flying time, it's always getting someone to accept your patient, once you've got a unit to accept the patient, then you've got to get a bed in the bed. Managers, the nurses have to give the bed, the doctors have to say they're going to be happy. You need to get a plane at a certain time. It's all, if the patient's really obviously sick, it all works really well. If someone's had their arm bitten off by a dog, everyone wants to help and everyone comes quickly. If they've got a classic ST elevation myocardial infarction, everyone wants to help. If it's a 29-year-old intravenous drug user who seems possibly septic or maybe have some kind of focal emboli to the brain and meningitis, no one really wants to help. Then there's always a reason why it needs to take a little bit longer. I don't know if that's something you find as well.
We find that as well, unfortunately. So interfacility transfers are critical to the safety of rural citizens, isn't it?
To you, when in Australia, usually when you ring, a rural doctor, often can be an experienced rural doctor or a junior one, would ring and speak to a junior doctor at one of the tertiary hospitals, and I don't know if that's the same where you are. And there's a phenomenon, I think, that a Swedish psychologist has described, I think, really influences things. That's called geographical narcissism. I don't know if that's a term that you've come across, but it's based on the idea that, in the past, all roads lead to Rome, and if you there's a famous map of New York where New York ends at the whole map is New York, and then there's a river, and there's this little blur the other side that's unimportant America and the rest of the world, where everything that, for an urban mind, everything that's important happens in an urban area, and they can't really imagine why people would go to work in a rural area. The only people who work there would be people who are not very good. Perhaps it works like Major League sport, where if you're good, you move up the league to the regional league and to the centre league. You would only be bad for out in the country. Or, possibly you're there because you've got a drug and alcohol problem, or because you've come across the medical board and they're punishing you for sending you to a rural area. And so you get, there is a mindset that from the start that the rural doctor is less intelligent. So you'll get a bit of urban splaining as an equivalent to mansplaining. There must be an equivalent in French to mansplaining. I can't imagine with strong French women they get the term mansplaining hasn't come across. So it's urban splaining, where you'll get the junior registrar at the tertiary hospital tell me, cardiac shock is a bad thing. And I think, I probably know that cardiac shock is a bad thing. Or they'll say, you're a long way from us. And I'll say, I know that I'm a long way for you. Although distance is relative. I don't know if you have meetings with people in urban areas, but it always seems to take twice as long for the person from the urban area to go to the rural area as it does for the rural area to come to the urban area. So if I have a meeting in Melbourne, which is 4 hours away, I come up for the meeting, go to the meeting and come back. But if someone from Melbourne needs to come to visit my town, they need to come the night before, they need to have accommodation, they need to stay, they have to have the meeting, and then, they have to have a meal, and then they've got to stay, and then they've got to go back because it's so far to come out to the regional areas. I think geographic narcissism is, a really important thing that you need to to get over to make transfers work. And I think the most important thing about it, it's something that rural clinicians internalise. You get those microaggressions each day saying you're not as good, and people start feeling they're not as good. So when you come and say to people, you know, we want to make this rural town, this rural hospital, a centre of excellence, people say all centres of excellence are in tertiary centres. In tertiary centres, you know, there's the Centre for Excellence in, you know, left ureter care, and, you know, the Centre for Excellence in stroke care. You can't have a centre for excellence in rural care. All we've got to do is be good enough. You know, we're in a rural area. We shouldn't push too hard. No, that's ridiculous. We just have to be good enough. If you're really good, you should be going somewhere else. And that's something to fight against. And you're absolutely right, Tim. And that's a little bit of the idea we have with the Living Lab Charlevoix, where we want to actually create an environment, make it technologically interesting, push the innovations, make people dream actually of the possibilities of being like an important center in rural emergency medicine and other fields of healthcare. But and you've read this project, and what do you think of it? Are you skeptical vis-a-vis the possibilities of this? What do you think? You've read it in detail. I think I like the idea of people being active rather than passive participants. I think that's an excellent thing. It really it's really something that I think you need to see, you know, and hear about directly in examples to really understand. I understand the concepts of where it's come from and how it works, but I'm really fascinated to see how it's going to work. I think it seems to be, one thing that seems to be critical to me is where you set the boundaries of what's inside your living lab and what's outside your living lab. Is it just health, or is it health and education, or is it or is it just the emergency department, or is it the rest of the hospital? Because I think, well, that's the other thing I think from geographical narcissism, is that when you're a little bit made to feel lesser, you tend not to be cross with the people in the urban areas. But there's, you know, horizontal aggression would be the word that they would use from other forms of things to do with status, and then you turn against each other a little bit. So you say, we're doing really well here, but it's a pity that the physicians are so bad. You know, I wouldn't let anyone see the physicians, but we in the emergency department are doing really well. Or, you know, we're doing really well, but, you know, the transport system here is terrible. And you end up arguing with, you know, or, you know, the emergency department's really good, but the paramedics are dreadful. And you end up having arguments with people who are in the exact same town as you and exact same work as you, but, you know, you start fighting amongst yourselves rather than working together. So I'm really interested where you've set your boundaries. What is inside the living lab and what is outside?
Yeah, so that's a work in progress. But the priority is really to, as we've studied rural emergency care across Canada, but more in detail in Quebec, it's really to see if we can reduce the gap between rural and urban and create an environment that will facilitate innovation and have people actually to create a dream, a project that is big enough to inspire, to have people dream about something, but small enough to be realized. But obviously, you know, every day I think there are good ideas, and can the Living Lab participate in helping us reflect on the pandemic, for example, or last week cardiology care in prevention in rural areas. So that's another issue. Let's speak about that.
Cardiology is not part of your living lab. They're outside your living lab, are they?
Yeah, we have no cardiology. There's no There are cardiologists that visit, but it's not a tertiary. It's not a tertiary cardiology center. But it's only an hour away from there. But it could be, for example, how to better train people in bedside ultrasound, even paramedics, and how to actually, improve the diagnosis and the immediate taking care of cardiac patients or shock patients, using simulation, for example, creating a sim lab, delocated or in situ sim lab. So there are all sorts of ideas and projects, but I'd like to talk about you. And we mentioned the term pandemic now because we've been called upon to reflect on the pandemic with the public health agencies, and Dr. Dupuis here. We've participated with them in the Living Lab, and it's a key thing for rural areas, the pandemic, because they've not had that many cases compared to Montreal, for example. And there is a risk. There is a big movement of tourists, and Charlevoix is a very important tourist area. And I'd like to talk about the pandemic because Australia had a unique perspective vis-a-vis the pandemic. And what has been, it's a completely different philosophy. So you told me last week, what happened in Australia? What are the difference between Australians and Canadians, you would say, in terms of this approach?
So I think Australia, perhaps the term would be, has dodged a bullet. I think the pandemic has not really, there's certainly been less people die this year in 2020 in Australia than would have died normally. The pandemic has resulted in less than 1,000 deaths in Australia. About 800 were in my state, but so less than 1,000 deaths in 20-something million people is not too bad. There is no coronavirus infections in my state for the last week. We sort of have runs of 1 or 2, 3 weeks with no infections at all, and then there'll be a couple of cases that come in through hotel quarantine. But Australia has shut down very hard, especially my state. So Australia is basically closed. It's very hard to get to Australia. So there are thousands of Australians overseas who can't get home because the borders are closed. The borders are closed both ways. You can't get out without the approval of the immigration department, and you can't get in because there's almost no flights, and they seem to be taken up by celebrities coming to make movies. But it costs $15,000 or $20,000 for a economy flight to Australia. So that's Australian dollars. So perhaps, I don't know, 10,000 US to get to Australia at the moment. And you just can't get there. They're just not flights. People are waiting months, 6 months or more to try and get here.
So you've locked down. Yeah,
and we've had 3 lockdowns we've had 3 lockdowns in our area. So lockdown means there's only 4 reasons to go out, which are for healthcare, to work if you've got an approved job, for 1 hour of exercise, and for caregiving. And there was for lots of last year, there was a 5-kilometre radius that no one could go more than 5 kilometres from their own home. So people really complained, but pretty much obeyed. They did. They set up what they called the Ring of Steel around Melbourne, our capital city, and it was like crossing the Berlin Wall. You had to show various cards and passes to go across. There were huge lines. Most people were turned back. And so they really protected rural Victoria from urban Victoria, but they shut down hard. Australians are pretty good at following rules, it turns out. There's lots of reasons people say so that we like to think that we're rugged individualists, but really when it comes to doing what we're told, we do it. There's a couple of reasons people say. People say either it's because we're convicts, we're all convicts, so we're used to, complaining, but when the guard comes by, we duck our head and do what we're told. Plus, Australia was built by government, not built by private enterprise. They discovered gold. The government got lots of money, built all the railways, built everything. So there's a bit more, at least, obedience with government. And Australians tend to do better when they're in a crisis. They're quite apathetic. We're quite apathetic most of the time, which is just the way we like it. But in a crisis, we like to do the right thing.
And so, with New Zealand, South Korea, Australia is for many a model of pandemic management. And our maritime provinces, under, I think, a participation of Joanne Liu, Dr. Liu has helped them, advise them as well. It's been remarkable. Here in Quebec, it's been a completely different approach, and we've talked about this. It's, the pressures of opening the economy, social services, the gyms and all this are quite important vis-a-vis, confinement. Just as of yesterday, we have 600 to 700 cases per day in Quebec right now. Most are in Montreal. And just yesterday, they announced that, pretty much outside of Montreal, they would pretty much open everything. And we've been, and the variants are increasing, mainly in Montreal. And so that's kind of, we're in the middle of spring break. So right now it's closed. We have a curfew for most of Quebec at 8:00 at night. And it's going to change on Monday, 9:30 p.m., the curfew. But most of the activities are going to be increased. Of course, we wear masks and things like that. So it's a bit of a risk-taking. And our government, I think, is doing its best, but it's been criticized with the mixed messaging. But of course, perhaps people think that, we would not we would not be able to obey the rules as Australians have. And knowing several Australians and having been there for a month a few years ago, I am surprised by the reaction, how Australians are able to obey those rules, and they were quite strict rules, let us say. I understand now you're just starting to be vaccinated.
Yes, I've got my vaccination now, so that makes me very happy, especially since I got it from my small hospital, which is next to a large port, almost in a large port. So when I worked a couple of nights ago at the big hospital where they haven't been vaccinated, I could laugh at them, which was fun.
Hey, Tim, I'm going to ask you one last question and then, defer to our students after, and then to the public. What is life in Australia? People have an imagination about what it is. The beautiful weather. You hardly have snow, actually, in most parts. But it is actually one of the most dangerous places in the world to live. It's not one of the most dangerous places in the world to live. It's a very safe place to live. There's 20 million people. There's life is different, there's all different kinds of life. Yeah, but you have those snakes.
Yeah, I know. I've got one just out there. I ran over it just before.
But crocodiles all over the place.
Yes, but the thing that kills the most people in Australia is bees. More people die of bee stings than snake bites. More people die from horse riding accidents than snakes and spiders and sharks and lots of scary looking things. But no one gets them. Australian snakes are incredibly poisonous, and we're all very proud when they say, one snake bite could kill 130,000 sheep if you dilute it. We're all very proud that all the most venomous snakes are in Australia. But Australian snakes keep to themselves. They have very small fangs. Their fangs aren't hollow. They've just got little grooves at the back. So that's most people who are bitten by snakes are either drunk or snake handlers or stupid snake handlers. Our local snake handler gets bitten every year. The last time he got bitten was by a taipan that he'd taken to a kindergarten to show the 3-year-olds. So this man is, he's a character, let me say. He's very entertaining to speak to, but if you stay away from snakes, they stay away from you. But
in your emergency department, on a typical day, for example, how many of those exotic animal or wildlife injuries would you have on a shift? Or is it just the myth? Like,
yeah, very. Oh, and then we would probably get 20 potential snake bites. Some are maybe 40 out of our 30,000 patients, but lots of people, they walk through the bush and they get a scratch on their leg and they don't see anything and they think it could be a snake, so they come in, they put the bandage on. Actually, this is the thing that's made our local paramedics happier than anything. There was someone on a walking trail that thought he was bitten by a snake, and so they sent the helicopter with the most highly trained paramedics who went. They don't often see snake bites. They put on a bandage, but they put it on the bandage so tight that when the person turned up in the emergency department, he was screaming in pain, just in agony. And all we needed to do was take off the bandage and put it on a little bit more looser, and his pain went away. But it was on so tight that he got muscle breakdown that we couldn't tell if it was a snake bite or not for ages, which made our local less trained paramedics really, really happy that even the fantastic paramedics can make a mistake every now and then. But was all fine. The patient was all fine.
Tim, I apologize. One last. So you were also you're resilient people. You've been through that big fire last year. Wasn't that something that was devastating for most of you in Australia? And what's the impact of that today?
So Australia always has fires. Australia is very dry. The whole country has been really developed by our Indigenous people who farmed really by lots of small regular fires to keep patches of open ground so they could hunt game. So all the fire loving vegetation has developed over the last 40,000 years. And if you let it go without that burning, when it goes, it is really explosive, amazing. They have firestorms that sweep through, and we like to live out in the country. I live right on the edge of a park, a national park that's all full of bushland. So, it is a big problem. It's never a big problem everywhere at the same time. So the big fires in 2019 were the other side of the state from me. So that didn't affect us very much. But, we have, we were hit by the bigger fires 15 years ago. But every 10 or 15 years, there's a big devastating fire. And every year there's fires pretty much. Apart from the odd year, which we're having now, which is called a La Nina year when it's all wet and rainy. But that's something people deal with. I live in a small area, and we thought that we're going to be very well prepared if there was a fire, because I'm an emergency physician. I live next to a fireman and on one side and a policeman on the other. So we thought if there was a fire, we would be perfectly organised. But our partners pointed out that if there was a fire, we'd all be off at work. So, the families would be looked after by a speech therapist, a psychologist, and an interior designer. So not quite as well protected as we thought.
Thank you very much, Tim. I'd like to open it up to our students on rotation. I'm just going to for the sake of time, just to point out Jen. So I just want to say, Tim, our rural rotation, leadership and innovation rotation has 5 pillars. So rural medicine, it has also physician wellness, or wellness in general, not necessarily physician wellness. It has also leadership, obviously, creativity and innovation. And there's also a 5th pillar that Karine is going to help me remind. So sometimes we pull them together. But in any case, we like to ask our guests to talk about the different pillars of this rotation. So we talked about basically having you here as well, talk about Australia makes us dream. It makes us feel good to think about Australia. I think we affection your country, and it's lovely to hear your accent, Tim. We talked about rural medicine here today a lot, and we're very lucky to have you. I'll ask you that open it up, but if people have questions on those different pillars that they've examined this week, perhaps that would be interesting. I'll ask Jenny to start off.
Hey, hi Tim, my name is Jenny. I'm not working in a health system, but last week we had a psychologist and we talked about the pandemic, and here we have kind of a lack of objective, like, okay, everything is closed now, but what's next? What we need to do all together to go to another step. And we heard that maybe in Australia, the government were better to give some like common objective for the people. So I was like really curious to hear about it.
At least initially, Australian governments worked very well together. So in the first weeks of the pandemic, the federal government, so we have federal governments and then province governments, which I imagine you do too. And so they formed what's called the National Cabinet, which was the Prime Minister and then the Premier of each of the governments. So they formed a new, not even sort of constitutional, almost like a war government, and worked together so they would set objectives together, and they made the decision that they would try and base it on evidence, and they have an evidence group that they base things on. So that was good. It's fallen down a little bit. The states argue a little bit and tend to close their borders to each other a lot. No one has visited Western Australia for a long time. They've just shut their border. But I think in setting goals, it's been tricky because no one really knows what's coming next. No one's really experienced. We've set the goal. Well, New Zealand specifically set a goal of having no coronavirus. We initially set the goal of just flattening the curve, and we were looking for success to look something like what's happening in Quebec, I think, where you didn't get a massive peak, but you still had many cases. But we managed to get things under control, which from about 800 cases a day down to 0. So for us now, we're looking for basically 0 community transmission. That's what we're looking for, because that's the situation we can get, and to stop cases coming out of hotel quarantine where they still manage to get through. We can't quite get that sorted out. But, I think we were lucky. There's, people in my state think we've done terribly. So they're very upset with our response to the pandemic, because we've had 800 people die, and they look at other states in our Commonwealth and say, well, they had 100 people die or no one die, so they feel we've done very badly. That's funny. We don't look to other countries and say, well, we've done better than that.
So Tim, I'm sorry, 800 people died. What is the population again?
800 people died in our state of about 6 million.
6 million in your state. Okay.
Yeah. And then 5 million in the capital city.
So how many in total died in Australia?
1,000, less than 1,000.
Less than 1,000.
980 or about that.
So how about Chantal? There's a student in our rotation.
Yes. Hello, Dr. Baker. Thank you very much. That's your talk is very, very interesting. I actually am very interested in hearing you talk about healthcare in the rural areas. I was fortunate enough in my last job to travel around the world, and I've been to your great country twice. And I was struck by the fact that I felt at home. When I was in Australia, it was a place in the world where I felt like I had the same cultural references. And I remember driving from Newman to Yandi in the Pilbara, and I mean, it's a 3-hour drive and not meeting a soul on the road. You know, that's very Canadian-like. So I'm very interested in hearing you talk about how do you think a country's culture impacts the shaping of rural medicine challenges. You've been to the States, you've been to Canada. I don't know if you've traveled to other countries, but as you told Dr. Fleet, you felt like we had a lot of similar challenges. So what do you think other countries maybe, is it possible to have completely different challenges because the culture is so different, basically?
There are certainly cultural differences. I think several countries, Canada and Australia and the United States especially, share that geographical separation, small towns separated, and I think but an advanced health system. So sometimes if you look in emergency medicine textbooks, they'll talk about resource poor medicine, and they'll say, Africa, Asia, and rural areas, but we're not really resource poor. We're resource separated. I think that's the thing that we share. I've had, a child come in working north of Alice Springs in the centre of Australia with what was said to be a cold, but turned out to be a cardiac tumour. And she, within about a day and a half, was on heart bypass in a world-leading tertiary centre. So, rural people do have the same resources for care in the system eventually, but we're just separated from them, and that makes it difficult. So we do share that. I do think Canada and Australia seem more alike than either with the United States in the setup of health. I think there's less financial incentive. There's an incentive not to waste money and lose money. But Australia I work in the public hospital system. There is a private hospital system that is optional that people can use for various things. But it's basically a public hospital system, especially for emergency and especially if you're critically unwell, where I read about the critical access hospitals in the United States that are closing during the pandemic because they can't make money, because they can't do the things that make them money. I cannot imagine in Canada or Australia hospitals closing in a pandemic. And in America, the death rate in rural areas is higher than urban areas. The death rate per 100,000 is higher in rural areas for most of the pandemic. It's dropped in the last couple of weeks, although it seems to have plateaued this week. So to close hospitals because they're not making money just seems very different. So I feel we are the same. But then, you have a very entrepreneurial system, and you get Operation Warp Speed, and you get pandemic vaccines where, we did our best to make a vaccine in Australia, but when they gave it to people, they immediately tested positive for HIV. So that was not ideal. So our vaccine didn't go anywhere. So didn't actually give you HIV, but it made you test positive for HIV. So, different systems have their strengths, but I think Australia and Canada, there is more a public service and community approach, and I think that's why it's interesting to see what you're doing.
Thank you
an interesting point, and just a bit of background. The critical access hospitals, it's a law. It's I think in the late 80s, the US actually, Congress passed a law where they required certain hospitals to have services being offered to rural people. And the level of services was quite high. Like you had people with MRIs, lots of specialists and all of this, because it was funded by the government. So if you didn't make that much money, you would be compensated. But even that kind of fell through the pandemic. So you brought up an interesting point there, Tim. How about our medical student, Nicolas, who's on rotation, who just gave us a call. He wanted to do a summer rotation. I said, do you want to sit in on our Living Lab leadership rotation? And he said, yeah, I'm interested. So he came to almost every meeting so far, hours and hours through medical school. I don't know how he did it. So Nicolas?
Medical student questions are always the hardest. Especially when you can't say, it's usually good in clinically, you can say, well, that's a difficult question. It'd be really good if you looked that up yourself and came and told me the answer in a week's time. I think that's the way to.
So, hi, Dr. Baker. And as Richard is explaining perfectly, I'm a second-year medical student. And you talked a little bit about this geographical narcissism. And I find that really interesting because I see the exact same thing in Canada, and it's probably everywhere else around the world. And my question is, how do you fight or change this kind of mindset as a leader or a director in your field? And at the same time, create an interest in junior doctors to come to rural emergency facilities.
So they are, two slightly different problems. So certainly I've talked about geographical narcissism in rural areas and about, the funny things, urban splaining and things, and rural people are nodding and yes, laughing. And I've given the same talk in urban areas and people go, that doesn't happen. That doesn't happen. That's ridiculous. It's ridiculous. It doesn't happen. So I'm not sure that we are ever going to change the fact that people in big centres are going to see mainly what happens in their centre and not outside. I think what's more important is to stop rural people believing that they can't be a centre of excellence, that just because they're outside the city ring road that they can't be good. I think it is interesting to see how you get rural students out to rural areas. So if you ask the College of Rural and Remote Medicine, they will say it's their pathway, that you need to have a pathway where people go to medical school rurally, go to their intern year, we have resident year and registrar, you can do your training rurally. And while I am sure that is part of it, I think the College of Rural and Remote Medicine undersell the effect they've had on the social capital they give. So I've done some articles with a journalist who is an expert in a sociologist called Bourdieu, who talks about social capital. And, in the past, to say you were a rural doctor was to say that you are not very good, you're not up to date, and you were there for some other reason. I think your most famous Dr. Osler is famous for saying rural doctors were like an amoeba of medicine, that undeveloped. So, that is a problem. And I think by having rural generalists, a College of Rural Generalism, showing people how difficult and how challenging and how rewarding it is to work in rural medicine, it makes people think that I'm doing something that is really important and really challenging, not just I want to have a quiet life. For our local doctor advertisements, I've taken, I really hate when they say come to work in our area, which is a lovely port, for a sea change. Come and experience our lifestyle and relax. And because it culminated with someone coming down for a job interview, and when I asked why they were coming, they said, I've come because I don't want to work hard. I've come because if you come to the country, it's relaxing. You don't need to work hard there. And that's a stupid thing to say in a job interview. He was not hired for not only for the attitude, but being too stupid to even hide that attitude, really. But I think rural medicine is hard. It is a challenge, but it is rewarding, and it is something that you should be proud of. And I think what rural generalism does is let students be proud that they're training in rural medicine. And I think pathways are important, but I think they need to be able to hold their head up high when they walk past their friends doing surgical training and pediatric training and saying, I am training in something that's difficult and worthwhile.
Thank you very much.
I hope you like that question. Merci, Nicolas. So I'm gonna ask. I don't know if Fatima is no longer on the line. So Fatima is one of the research coordinators of our research chair, and she's in Africa right now. So perhaps it's not possible. So I'd like to actually open up for questions to anybody. We have lots of interesting people online here today, Tim, and I'd be glad to just pick on them randomly here. But I'm sure lots of people. So I'm gonna go for the first question here to Dr. Jean-Luc Dupuis. So Jean-Luc, Dr. Dupuis is a well-established rural doctor in Charlevoix, in La Malbaie. So, and been there for several years, many years, I would say, Jean-Luc, not to reveal your age because you look very young and you're certainly young at heart, but he's a pioneer in this field. And we had him on one of the interviews like yourself a little while ago. So celebrated guy in Charlevoix. So Dr. Dupuis also just been signed up today by Public Health of Quebec to help manage the pandemic in Charlevoix region. So Jean-Luc, please go ahead.
I was just fascinated. Thanks, Tim. I was just fascinated by Nicola asking the same question as a second-year student that I've been asking myself for more than 35 years about urban narcissism. Well, I've seen them all. I've seen them both because I saw some specialists coming to work in remote area and being in real bad trouble at the operating room or the emergency room, and they took a big dose of humility. But I think the best thing is what you said, that people have to be proud and looking forward to work in a rural, but it has to have more. It has to be recognized by the university as a subspecialty, and it has to be some integration with the tertiary hospital where you live by. Like here, Quebec City is a referral center. So I was just wondering how is your rural setup is integrated with your tertiary hospital? Because that does improve a relationship. And I think in the future, with telemedicine, which we've been waiting for myself for more than 25 years, I think seeing and discussing with the emergency physician in the tertiary or the specialists in urology, dermatology, having a close relationship will bring more respect between the rural area and the specialized hospital. What do you think? How do you handle it in Australia? By the way, I was in Australia myself, in Melbourne, Canberra, and the Great Barrier Reef. I enjoyed myself very much. Thanks for talking to us, Tim.
So I agree. I think what your experience tells you that knowing the people you are talking to is borne out by the evidence too. I think when they look at referrals made where the referrer and the referee know each other, the quality of care is definitely higher, and it is more collaborative. I think that is definitely true. It can be difficult, perhaps because of the narcissism we've talked about, but also if you're in a big hospital, the patient that's directly in front of you always seems to take precedence over the patient that's at the other end of the phone. and it's very difficult to get around that. And I also think rural clinicians sometimes can feel that asking questions is a bad thing too. Certainly we have sold generalism as people who are independent, and sometimes we can can see asking for help as a weakness. One of Richard and our colleagues, Lucy Walters, has a saying that perhaps she stole, that you need to be courageous to work in rural health, but not a cowboy and not a coward. So you need to asking questions is a sign of mature practice. I ask questions every day. You need to ask questions as people who know lots more than I do. And I imagine you know that too. And the very setup of the question makes it clear that you know that. I think we don't do telemedicine very well in my part of Australia. I think it is very piecemeal. I think that the telemedicine is often set up for the convenience of the person providing the advice rather than the convenience of the people requesting the advice. You have enthusiasts who set up we have a brilliant stroke telemedicine unit, but you've got to buy their own machine and use their software. And it is fantastic. When you ring them, it is fantastic. But then we have a separate system for cardiac care, and that uses different software and different hardware. And we have a separate system for ophthalmology, which uses different hardware and different software. And it gets very difficult. Other places in Australia do much better. Western Australia has the idea of a virtual emergency department and a virtual hospital, and they basically recreate what happens in larger hospitals, that people there, if they get a difficult question, will refer to an emergency physician, and if they don't know that answer, then they will refer to various subspecialists. And if it's a senior person ringing, often they'll just go straight to the subspecialist. I think to have that kind of unified system is really important. Telemedicine never seems to fall over because of the quality of the equipment. It's always getting someone to answer properly on the other end. Is this something a problem that you've solved? This connection with your network? We sometimes do well and sometimes don't do well.
I just want to add up the last thing is I saw some changes when the specialists, the government started to pay the specialists for phone consultation. And at that time, there's been a change in that urban narcissism as far as the specialists saw the call coming as a case to be able to give a consultation, and the physician on the other line being not diminish, but somebody who was at the point of asking the same question as somebody would be in the emergency room of his own hospital. So basically, it's just a question of respect, and the specialists were not paid in the past to answer these thousands of calls, and they would like, for them, rural medicine was just people who were second-class doctor. But it's changing. It's changing.
I think there's always a question about whether your advice should be to your local tertiary centre or whether it should be to a separate entity that's job is to provide advice. And in general, I tend towards thinking a central advice section is good because it becomes their profession then to answer questions from rural hospitals. And it takes skill, as we know now, because we do some telemedicine consultations with patients. It's a different skill set. You need to know what's there. You need to be able to collaborate. And if it's your job one day a week to to be on the line that takes advice from other people, then you get good at it. If you're someone who wants to do good quality work, and in general, most doctors want to do good quality work. And the other thing I think is you really need telemedicine advice for nurses, because we've had similar things in smaller hospitals. I can remember a case that I've written about with a junior doctor having a severely unwell pediatric asthma case and wanting the nurses to make up an infusion, and the nurses refusing because they'd never made this infusion before, and the stress that caused. But really, what would happen if that was in a bigger centre is those nurses would consult with other nurses, say, yes, what you're doing here is right. Yes, that's what you're doing. So, it makes me frightened sometimes when really small hospitals are setting up the underwater sealed drain for chest tubes. Really, it would be great to have someone. You really need that nursing advice. And as doctors, we always feel we understand all the nursing equipment until the actual moment that we're asked to press the button or do the connection that we're actually meant to do. And then we realise we're better at asking for things to be done sometimes than actually doing them, even rural doctors who are probably some of the most hands-on doctors.
Thank you, Tim and Jean-Luc. So I could, I don't know if anybody has another question. If not, I could just, Mathieu. So Mathieu has a question here. We have several people. Karen is probably checking the hands that are being raised. I'm going to go with, I just saw Mathieu. So Mathieu works, he does like our videos and social media, and he's really an important creative person in our organization. And he actually will set up the podcast you'll be famous for after this. And he has lots of juicy quotes there. Probably took them all, like one of the very interesting. I'm glad you're there.
Yeah, but thanks. Did you do Richard's? Did you do the website for your organisation for that?
All right. So our website. The website have to be rebuilt. We're working on it right now, and
it made me very jealous. It's beautiful. It is beautiful. And my website is so terrible, and I keep giving it to people in my small organisation to fix. But they look at that and then they give up. They don't want to compete at all with your fantastic website.
All right, the next one will be even better. So brace yourself. I got a question about in the Australia. First, here we think that you handled the pandemic very well, but I'm very curious to know what do you think that Australia could have done better, even if you were very good at it, and also what Canada should do right now about the pandemic from your opinion.
I think what we could do better, I don't know. So we worked hard to provide evidence-based guidelines, and I worked hard with the College of Emergency Medicine to write rural evidence-based guidelines. And it seemed to me that every scenario that I anticipated that we would get to was completely wrong. The pandemic has gone completely the opposite way that I thought. So I initially wrote guidelines when I thought that rural hospitals would be completely overwhelmed. And so wrote guidelines for that, which is completely wrong. They weren't overwhelmed. Then I wrote what we would do because the pandemic had completely gone. And as soon as I wrote them, then the pandemic came back. So I'm not an excellent person at working out what will happen. But I think what Australia did well was it coordinated well together. And what it has struggled with has been hotel quarantine. So we still don't manage. We came to realise that the people who are security guards and the people who work in low-paid aged care are the same socioeconomic group. Neither are well paid and neither are well respected. Really, we've really taken a lot of money out of aged care. So people would come home from working in hotel quarantine, spread the virus to their partners who were working low-paid shifts, not as nurses, in aged care, and that got into our aged care. So we understand that we need to understand that and try and separate that. And we also need to realise that our aged care system is incredibly underfunded, that people are being fed for, on average, would be something like about $4 American per day, buys the food for an average person in Australian aged care, which is ridiculous. And so, it has picked up not so much problems with our pandemic system, but problems with our care system in general. Our aged care system has got to change. What to do for Canada and Quebec, I don't know. In general, I don't like to tell people what to do. I like to say, especially in small rural hospitals, because everyone is so different, but I like to visit a lot of and hear about lots of small rural hospitals and say what other small rural hospitals do and let people choose. So what we did when we got to your, I think if the leaders from Victoria came to Quebec, they'd shut your borders and lock you down, and they'd do that for 8 weeks until the virus went away. And in general, for us, that has allowed trade business to go okay. We've spent a huge amount of money with the government paying everyone's wage. In fact, more than their normal wage in some cases, to keep the economy going. But I don't know whether that would work. When you're so integrated with the rest of Canada, I can't tell you whether that would work for you.
All right. Question like that. Here we got 3 days in quarantine when we arrive in Canada. Like the quarantine at the hotel, it's brand new and it's only 3 days. And if you test negative, then you can go back home and wait until you get another test 10 days after. How many days are the quarantine in Australia when you get in?
12 days.
12 days in a row at the hostel.
12 days paid for by the person who's quarantining.
All right. And all the cases that get out of there get out from the hotel by the employees. Is that what you're telling?
They stay in there where they have tests on several days, and they are really. I think there may be some change. If you test negative, you may be able to come out of your room for a short amount of time. Nobody is saying positive things about being in hotel quarantine. We had the Australian Open tennis, where we had all the high-profile tennis players come to Australia, and they were all locked up for 12 days. And then there was a positive case, so they were locked up for a few more days. They were very unhappy. They were very unhappy having to wash their own clothes. They were very unhappy about everything. As a tennis star, you don't get locked in your room for 2 weeks, no practice, look after yourself. But that's what we did.
Thank you very much, Mr. Baker.
So I see Benoit and I think Sonia. Karine, is that pretty much it?
Moi, j'ai vu Benoit, Sonia, puis tu as nommé quelqu'un d'autre, mais je l'ai pas vu.
Okay, Benoit, Sonia Sauvé. Benoit's a paramedic, and he did this leadership and innovation rotation. He's an advanced paramedic. There are only 30 of those, pretty much, more or less, in all province of Quebec. Most of our paramedics are not. Lots of them are trained in advanced, but there are restrictions as to what they can do. And Benoit is one of the rare that has this training, and he's in Charlevoix. Benoit.
Hi, it's really, really interesting. I've been in Australia 15 years ago, and just hear you talking reminds me of the good time I had there. My question is about, as Rick told earlier, Charlevoix is about between 45 minutes and 1 hour and a half from Quebec City, where all the major trauma or cardiac centers are. When in your rural hospital, can you retain some specialty, or most of them are transferred? And what's the logistic? Is it taken care by the sending hospital? Is the paramedic taking care of everything, or the staff of the hospital is doing the transfer as here?
So I think there's a difference between what is said to happen and what is really happening. I think around the turn of the century, the real dominance of a trauma system model was a great advance forward for rural care, where we were finding missed opportunities to save problems in rural care. And so the idea would be now that for most places, people are taken directly into the trauma centre by helicopter from the site of an accident. So they would fly directly there. And so if you ask the ambulance or the trauma centre, they would tell you that 95% of people get their definitive care in a trauma centre. And they would say that you go directly by paramedics. And that does work a lot, but there are only 5 helicopters for the whole region. And often there are multiple injuries in a same area. And I don't know if it's the same in rural Canada, but rural Australians are fairly reluctant to call paramedics. They like to be independent and do tend to turn up to small hospitals, critically ill, in the back of a car, or bring their critically injured child in the back of a car, or they'll fall off the top of a large shed and say, I'm not really that sick, and they'll turn up and they'll have a hemopneumothorax and a fractured femur. And so rural hospitals are still part of the system. Our goal would be, when possible, to get people directly with the paramedics to the trauma centre, but a reasonable number still do come to regional centres and even our various smaller centres. And you're right, that does cause a problem, because when you see less patients or less critical care patients, your skills do go down and your resources to deal with them go down. So I think that is something we're working on. I'm trying to convince our trauma service that the paradigm at the moment is that rural hospitals refer to the trauma system. So they are outside the trauma system, they'll stabilise the patients, refer to the ambulance, and then they'll go. But I think rural hospitals really should be part of the trauma system, that in many ways for critically ill patients, a small rural hospital is like an ambulance with the wheels knocked off. You should be able to do all the same critical care skills. You should use all the same protocols, because it's doesn't make sense starting on one protocol and then changing to another. And I feel that would be an advance for trauma. I'm also very interested in the role of paramedics working in rural hospitals as well. Like we have extended care nurses. One of my colleagues, who was my research fellow now, has set up a course for paramedic practitioners to have them working in small hospitals, emergency departments, seeing other things as well. So I think I would like them to be better integrated. I've read some of the research from your organisation on about Quebec being still fairly well set up with regional CT scans and things, but it is I'd like them to be part of the system. Is that what do you feel from a paramedic point of view? Is that the way you would like it to, or can you see a way that all patients can go directly?
Well, I used to work in Montreal, so big urban area, and now I'm in Baie-Saint-Paul, so it's totally different. I wear the same uniform than before, but it's totally different job. So with some things are more difficult and something are more harder. And the thing I find harder as a rural paramedic is the retention of skills. So I wonder, I understand that if you send all your trauma to the big trauma center, the orthopedic surgeon that treat 20 cases a week is better than the one that treat 20 cases a year. So I don't know exactly. And again, we sometimes have trouble transporting person because they don't want to go to Quebec City. They want to stay in their region. So it's, as you, I don't quite know if it's better to keep the more specialty in the region or to try to send everything to the major trauma center or cardiac center.
I like the way that rural paramedics still feel part of the whole state's paramedic system. I don't find in general rural paramedics feel less skilled than urban paramedics. Maybe that's different in Canada, but certainly in Australia, the rural paramedics are very much part of the same system, part of the same organisation, do the same scenario training, have patients for a lot longer, and feel that they are very good. So sometimes they do better with their self-belief, I think, which is good. Perhaps that's just the type of people who choose paramedicine. You need to be able to believe in yourself a lot to be by yourself. But it is a tricky question, and I don't think you can ever. I think you really should ever seriously think about rural emergency care without thinking about paramedicine. They are so interlinked that you need to have them in your thinking all the time.
Absolutely critical, and we're happy to have you part of this team, Benoit. Thank you. Excellent question. I think Sonia had a question for a long time. Sonia is a friend of Chantal. She's from formerly from the Cirque du Soleil, and so.
Thank you, Richard. Yes, hi, Dr. Baker. Thank you for your presentation. It was really interesting. I have a question about, I'm curious to know if you have concrete examples on how is the medical responding or dealing or integrating social challenges that is specific to rural areas. Let's say maybe specific types of poverty or ethnic diversity. Is there concrete actions that are taken, let's say in your facilities or around your rural facilities? I'm really curious in knowing how do the medical integrate the social challenges.
So I'm happy to tell you about one thing that we are doing, which I think is good, but also acknowledging your question highlights an area where we're not as good. I don't think we're as good at integrating with social issues as we should be. And there are many, rural poverty and is a huge problem. Indigenous issues too. Most Indigenous people in Australia live in a regional Australia, so we're not fabulous at doing that. But we do have a program that we have published on before that is to do with the impact of alcohol in rural areas. So we've taken it was first started in Cardiff in Wales. So for every patient who comes into our department for a couple of years, we've asked, have you had any alcohol in the past 24 hours? How much have you consumed? Where did you get most of that alcohol, and where did you have your last drinks? Looking at what's the load of alcohol in our department, and then looking at where people are getting their alcohol and drinking the alcohol and getting injured. And we've used that information to feed back to a community board called the Violence Prevention Board, which is the local council, police, paramedics, and hospital and public health, to look at can we decrease alcohol-related both violence and injuries. We found out that while we originally thought that most of our alcohol-related injuries were coming from what was perhaps generously called our local nightclub in our local CBD, but in a small town, you can imagine the central business district is not that big, and our nightclub was really just a hotel with more lights. But we found that most people are buying their alcohol at supermarkets because it's cheaper. And they're drinking at home and getting either injured at home or being violent, having violent interactions with their family and friends at home, including domestic violence. So we have used that the police have been very good. They've used that to change the way they are policing. So rather than walking up and down our one and only nightclub strip of 3 hotels, they are now spreading themselves across the community so they can respond more quickly when they need to domestic violence and other issues. And we are putting pressure whenever a new packaged liquor outlet wants to come into our town, making sure that the council considers the social impact that will have if you put another packaged liquor outlet in a place that has fairly poor socio-economic support. So I think that's something that we have done. Perhaps alcohol is one of the easiest things to do, but I'd like to see us do more of that. I'd like to see us. We know that that the presentation rate of people from our local Indigenous community is lower than should be just on population base, which obviously means people are choosing other points of care than us. We'd like to try and work out what we're doing to stop people from coming. So there are a number of issues like that, and certainly we're a public health system, but there is still a lot of expenses. So we have a crazy law in my state that if you come to an emergency department in a big town or city and they send you to another hospital, then the hospital pays for your transport, which is many thousands of dollars. If you come to a small rural hospital, then the patient has to pay. So we find someone will come in and they'll be really unwell, say, a 65-year-old person with sepsis, and they need to go an hour to the nearest hospital, and they should be on intravenous fluids, and their blood pressure is low, but they won't go by ambulance because it'll cost their family $3,000 or $4,000. So they'll go in the private car, and then they arrive at the regional hospital incredibly unwell, with the regional hospital being incredibly unwell that they've come in that way. So we're really doing our best to change which is an insane and discriminatory, really, law. Because just simple rules like that, I've heard, but I should be able to remember Richard's quote that he uses from someone saying the real difference in health outcomes is not rich and poor, but rural and urban. And I think that holds for us too. So we are working on it, but need to do better.
Very much.
Tim, thank you very much. We're at the end of this interview here today. I really thank you so much for your time. I would like to do something a little bit different now and just have a rapid fire, just going rapidly to everyone. I'm just going to name you and just going to tell me one thing that you took from this interview. I'm going to ask Sonia Sylvain, our chair of the department, family medicine. So she's our boss, and she's part of the Living Lab. So Sonia, what take home should we take from this?
Urban narcissism.
Urban narcissism. Excellent. Karine Latulippe, what do you take? What's the key thing you thought?
Emergency that inform public health.
Emergency that informs public health. Excellent. Mathieu.
That Australia get a COVID case from the employees of the hostel management COVID pandemic.
And Mathieu Tremblay?
It's fun to know that they also have the same situation between like urban area and rural area. So the difference between the both it's kind of similar here. So it's fun to know that.
We don't feel as alone. Nicolas, medical student.
All the challenges of rural emergency medicine.
Chantal.
Well, we can always do better. There's still a ways to go.
Et Sonia, sauver.
Patience, rural, patience power.
Jean-Luc?
Well, I think that we're making great progress in rural area compared to what it was 30 years ago. And I think Living Lab has got a lot of future, and it has to be part of the academic process, and that's the way to go. I believe very, very much on the integration of structure like the Living Lab for rural area.
Thank you, Jean-Luc. And Jenny?
The rural recruitment challenge, that's exactly the same than here.
Nice. And I just want to close up by saying how always impressive it is to hear all the depth and the width of your knowledge, Tim. And I think I forgot, and it really touching to have you with us for 90 minutes. It's a long time. You're a busy guy, and you're a generous leader. And people don't see this, you standing up, but I have pictures of you and I together. You probably measure close to 7 feet.
No, my son is now 6'7" and towers over me. I'm about 6'4".
You are a giant with a kind heart. And Benoit, maybe I forgot you. Just one little message. What's your take home?
Well, even if it's at the other end of the world, and we, as a paramedic, we always see the Australia as the goal to achieve. Everywhere in the world, we have our ups and our downs, and we have to learn from everybody. And some things are maybe better here, some things are maybe better in your place, and it's really inspiring.
And Tim, will the next Living Lab be in Warrnambool, Australia?
Certainly will if you come out and visit.
Maybe on my sabbatical. So, I want to thank you all for being here. Merci tout le monde d'être là aujourd'hui. C'était vraiment le fun. Merci.